Good afternoon, everybody. Welcome once again to the Royal Society of Medicine's COVID-19 series as we get to episode 64. Now, our guest today is Robert Dingwall, Professor of Sociology at the University of Nottingham, where he founded the Institute for Science and Society. Belongs to lots and lots of government advisory groups, as nearly all our guests do actually, although his record goes back quite a long way on this, to Robert, even to the days when they actually were secret. Now everybody knows who they are, and you're on too many that I can even be bothered to list them. Now that he's retired, he tells me that he's as busy as ever, but now he's able to do what he wants to do and say what he wants to say. So absolutely ideal for our webinars. Now, I'm pretty sure, Robert, we're going to get a kicking at the RSM very quickly, because as I said, this is episode 64, but you are the first sociologist we have ever had on the program. And I think you're going to begin by telling us off and saying that if you want to understand pandemics, you have to understand sociology and the social. Personally, I am convinced, but nevertheless, give us a kicking and start to make the case for what have we all been missing during the last year.
Well, thank you very much for inviting me at last.
Touche.
I think the core issue, Simon, is this, that alongside any pandemic as a biomedical challenge or a public health challenge, a pandemic is also a societal challenge. And that was recognized quite early on in the original pandemic planning around 2005, 6, 7. And the structures of response and management were organized in recognition of that. But somehow or other it got forgotten last winter when COVID-19 appeared in the UK, and it's never really quite been recognized again since. And I think many of the problems that we've experienced in dealing with the pandemic in an appropriate fashion come down to a failure to recognize that, you know, this is not just a challenge for the medical world. It's not just a challenge for the public health world. It's not just a challenge for the biomedical sciences, but it's something that affects the whole of society, and it needs a whole of society response. And it needs the social sciences collectively, including obviously my own discipline, to be part of that.
I mean, a few people would disagree, but I mean, I remember the period you're talking about, and I actually was on stage at that time. But I think you're talking about the creation of the Cabinet Office and the civil contingencies and all of that to have a central control of the next pandemic.
Well, that was yes, I mean, that was certainly the original plan. That was what was envisaged in the influenza pandemic planning, that the control, the core management task would be in the Cabinet Office. The Department of Health would report into it. Obviously, the Department of Health would have a big role, but it was this central principle. This is a civil emergency, like all other civil emergencies, and it should be coordinated on a cross-government basis, rather than as something that is specifically owned by the health and biomedical world and led from there. And this was quite distinctive in the European context. I went to quite a number of meetings where the UK response was being admired by colleagues in Europe, precisely because of this recognition of the societal challenge, and that, you know, the problem had not been dumped on the Ministry of Health in the way that it had been in most of mainland Europe.
Okay, but what do you think we have lost because of that? Well, I mean, we had Gus O'Donnell, who made a strong case that we should have had SAGE should have included as many economists as it did epidemiologists, was I think his words. But of course he was an economist, and one could also say, of course, you're a sociologist. You would say that, wouldn't you? Not that I mean it, but you know what I mean.
Yeah.
But what do you think we missed, or what opportunities were missed because of that? Gus was pretty clear on the economic side.
Well, I think there's always been this issue around the proportionality of the response and the the strategies that have been adopted in the longer term. I mean, the whole SAGE model was set up to deal with civil emergencies.
Mm-hmm.
I think Gus O'Donnell was one of the architects of COBRA and SAGE. And what you've really seen was, COBRA, it's about floods, natural disasters, terrorism events, where you may need a short-term body of scientific advice to complement the responses in the civil service and government, and to inform them over a relatively short period. And he'd never, I think, envisaged this kind of continuous presence, this sort of continuous stream of advice, this sort of Topsy-like growth of a penumbra of advisory groups and committees. I mean, when I was appointed to NERVTAG in 2017, it was a horizon scanning committee that met a couple of times a year.
Yes.
To receive reports of new influenza viruses in Chinese ducks, and were they a threat to humanity? And then all of a sudden it falls into the orbit of SAGE, and is transformed into something that it was not designed for, or that the membership was not fully assembled for. And I think that's been the experience of quite a lot of groups. Others have been set up on an ad hoc basis. They've been shaped by the sort of invisible colleges, as we sociologists of science would say. I mean, other people would say it's inviting your mates, but I mean, it's a little bit more subtle than that. That people go to the people that they know to look for advice, to create bodies of, to create inputs. And that again has tended to focus the SAGE network on the one problem that we have here is COVID-19. It's not COVID-19 in the context of the whole of British society at this time. And the other challenges in healthcare, challenges in economy, challenges in the mental health and engagement of the people. It's all about how do we control COVID, and it's not fair to criticize SAGE for that, but it's to recognize what that network was created to do, and to some extent that it was not designed for the purpose that it has acquired.
Okay. Let's then go through this in stages then, because I've been looking at some of your earlier work, and I know you're a great fan of Philip Strong and some of his work on pandemics. And I thought we would perhaps go through some of the stages of which he outlined, and I know you've amplified in your own work as well. And I'd very much like to talk to you a little bit about fear and the pandemic of fear, which was, I think that's Philip Strong's phrase rather than yours. But I know you identify with that. So let's talk a little bit about fear and how that was generated and what consequences that has had.
Yes. Before I come to that, Simon, let me just take a brief step back and remind people what the core questions of sociology are. I mean, every social science has its core question. And in sociology, it's about the problem of order. How do people create orderliness in everyday life? How do we sort of hold back a world of randomness, uncertainty, disorder, chaos, and make it stable enough to carry on everyday lives? And secondly, and from that, how do we come to have the particular order that we have? Now, what Phil Strong recognized was that pandemics turned many of our assumptions about social order, both as, if you like, the orderliness of everyday life, and about the way in which institutional arrangements operated. It turned them upside down. It destabilized them. It was a point of threat. And in that context, the initial response to this was quite appropriately one of fear. What is happening here? What is going on here? All the things that we took for granted are suddenly turned upside down. It's, if you like, uncreative disruption. And within that, as he pointed out, he was writing about the AIDS pandemic of the 1980s, but his work went really right back to the Black Death and was looking at reactions to pandemic and epidemic disease over a very long historical time span. The first thing that you see is the pandemic of fear. And he argues that, this is a perfectly appropriate thing. Something has come out of the blue, something that was completely unexpected, something that was novel, something that we've never seen before. And how on earth do we deal with it? And so you can go back to January, February, March last year and say, look, there's this entirely new infection. The only coronaviruses that most people are aware of are MERS, which is not particularly infectious but quite lethal, and the first SARS, which was fairly readily contained, but was clearly a virulent disease that posed considerable risk. And in that context, and for that short initial period, all sorts of extreme reactions occur. The interesting thing in this context is the way in which that fear has been sustained and amplified. If you compare the present situation with the early years of AIDS, of HIV/AIDS, again, you can see much of the same fear being expressed by healthcare workers, by ordinary citizens, by people who are involved in dealing with the sick individuals, or the individuals who are infected. But that fear fairly rapidly gets diffused by the recognition that actually it's not that easy to catch HIV unawares. It's not the same sort of thing as you might be wandering down the street and a random jogger goes past and suddenly you are fated to die. If you go back to March last year, well, maybe it's looked a bit like that. Now, 12 months on, we know the random jogger going past is almost certainly never going to infect you. Outdoors are as safe as they get, as safe as any scientist will tell you that it's safe. I've yet to find a scientist who could find zero risk in any situation. But there are risks that are so unimportant that you disregard them for all practical purposes. But what's interesting is the way in which the fear has never gone away. The fear has been sustained, that we've had institutions of surveillance put in place, which have, on the one hand, allegedly been for our protection, on the other hand, are constant reminders of the risks of everyday life, the risks of stirring from our homes, the risks of interacting with other people, even the risks of stepping outside to seek healthcare for other things that might be troubling us. And so that's what we mean by the, if you like, the pandemic of fear.
Well, let me put 2 points. The first point is going to agree, but the second one, not quite so, is that at the start of the pandemic, I do recall that there was data showing that actually the public were not alarmed enough about what was happening in China, and were indeed drawing on a previous pandemic, the swine flu, which you and I had some involvement in, and when of course we know that no one really took it very seriously. I think only 1% would avoid public transport during the swine flu epidemic, and therefore there was a need to create, if you want, fear. I think they would call it awareness, but awareness is fear. But wasn't that totally justified by the situation?
Well, I think we've always had this problem understanding the context and the proportionality of responses to COVID-19. I mean, even as long ago as last February, the World Health Organization was pointing out that in Wuhan, 80 to 85% of the people who had contracted COVID-19 never needed to go near a hospital, that it was, for the most part, a mild to moderate illness. I mean, it took a while for I think, for the scale of asymptomatic infection to be recognized, but that the sorts of representations that we've seen in much of our mass media over the last year, which would lead you to think that contracting COVID equals hospitalization, equals intensive care, equals high chance of dying. That was never the situation at the beginning. Now, I think there were genuine concerns about the potential threat to the healthcare system back in February, March, the potential for overload with the small proportion of people who were getting seriously infected. But I'm not necessarily sure that the public perception of risk back in February, March was so far off the mark.
Well, I think people might argue with that. And you talk about, kind of visual imagery of fear. I think you're talking about the constant reporting from ICUs, etc. But those pictures, we can hardly expect news media not to report those pictures from Italy of an overwhelmed healthcare system, and indeed, people dying on corridors. I mean, you really couldn't expect a journalist not to report that, and not in a reassuring way.
Well, indeed, but I think we might also want to bring the perspective from the sociology of the media to this, and to recognise the drivers of journalism, and particularly with television news, the importance of visuals, the importance of the importance of danger, the importance of threat. There's a lot of writing in the sociology of media on the role of fear in media narratives, we have. I entirely take your point, Simon, that you cannot expect the media to overlook this, but what we've never had is this sense of proportionality, that we have intrepid journalists who are going into intensive care units and sort of whispering in corners, like as if they were David Attenborough with his gorillas. But what we've not had is the coverage of the people who would never have known they were infected if they hadn't been tested. We've not had the sort of everyday experience of many of the people that I know who said, well, it was a bit rough for a couple of days and then I got over it, and what was all the fuss about? And some sense of, here is the context. That context has dropped out of the story, and so we do have, and I'm sure you'd seen it as much as I have. You stand half a meter too close to somebody in the queue to get into a supermarket, and they start quivering with fear because they think this is a recipe for instant death. And that, I think, is something that I would frankly very much lay at the door of some of our media organizations, is the failure to put the risk in proportion.
Yes, I mean, I take your point, but as we also know, and again, other people have commented during this series, the public perception of risk is not a statistical one. It's not based on the way that experts conceive of risk, as you know, and it's not based on statistics. It's much more heuristically, and it's much more based on emotion. And you could understand why, with the the pandemic is transmitted in a different way to HIV. You could understand why the fears on HIV would and the stigmatization would go. But if you've been watching this recent series, of course, it's a sin. I think it took a lot longer than it should have done, and was pretty terrifying for those involved. But there are differences. That's right. So I just wonder if you're being slightly unfair to people who do feel threatened by the other, as it were, and particularly the other that comes too close, which leads to the question, of course, how close is close? Well,
indeed, and I mean, we might want to say a little bit more about that, but I think the issues about the responsibility of governments, of scientists, of media professionals to avoid amplifying those fears. And that I think is that I certainly wouldn't blame ordinary citizens for having that emotional response, because that's what's being communicated to them. I mean, that's what the psychologists on Spy B said that ought to be communicated to them.
Yes.
And it's a very interesting contrast with the way in which the then CMO, Don Lacheson, responded to HIV. I mean, some of our older viewers may remember the Tombstone ads and the
Yes.
the attempts to generate fear in public messaging. And the ad agency who put that together came back to Donald Acheson with proposals to continue the fear-based campaign. And Acheson, it's all in the Public Records Office now. Acheson said, no, we're not having it. This is not appropriate messaging in public health terms, in government terms. We are going to do something different. We're going to inform, we're going to educate, we're going to support people and engage with them. We're not going to try and make them frightened. And the messaging changed very considerably, and you can see a very different vision of the relationship between public health and the people in the responses to HIV. And that actually carries through into the influenza planning. Things like the flu buddy scheme that was envisaged, where if you were too sick to go and get your antivirals, you would have a nominated person to go and get them for you. And that was a direct lift from the HIV buddies, which developed actually in civil society rather than within the health system, to take where people were taking care of each other. And that promotion of sort of community activity and community solidarity, it arose here in March, but it took a while for it to be officially recognised and supported.
Okay.
I think we've had a problem with a much more expert-led response, to this pandemic, and a fairly narrow base of expertise in doing that, which might be the appropriate moment to move on to, well, how close is too close? Because I think that's quite a nice example of the way in which a network constituted to address a problem designed as, how do we fix this virus?
Yep. Okay.
Includes certain kinds of knowledge.
Let's also acknowledge what the kind of chats and questions are saying. Several people have pointed out, and of course you're not contradicting this, but you can't ignore death and dying, and the risks to the NHS were not negligible. They were serious and severe. But I think you would make your point you're making is that's absolutely true. But of course they have changed over time, and other people are saying, at what point does do our measures become disproportionate? And referring, for example, to the long-term reactions to 9/11 that have gone on for 20 years and things like that. So just to sum up what people are saying, and I'm sure you will come to some of those as we go through. But let's also talk about what's near is near. And let me start off by asking you first question, which I heard you talk about on the Today program, was very impressed. When I can't remember if it was actually you quoting this, but it was when people were getting very upset about pictures of people on beaches. Do you remember all the crowds on Brighton Beach and things like that? And I think you said, as far as you knew, no one had ever caught COVID from a beach. And I've checked that with my friends in the trade, and they say, yep, that's right. No one has. So let's start out with what goes on when people are close, but not close, as it were.
Yeah. Okay, it was actually Mark Woolhouse, who's the
yes, it was.
Who said that.
Yes.
But it was, sociologists of science were very interested in what knowledge gets into policy and what gets left out, and the ways in which the social organization of scientific and social scientific knowledge can shape decision making in ways that we don't always recognize, and that by having a particular set of expertise built, if you like, baked into the SAGE network, certain things get selected in and certain things are left out. And the understanding of crowd behaviour was quite a nice example of that. It's something that sociologists and psychologists have studied for well over 100 years. And we know quite a lot about it. We know that crowds are not the sort of random aggregates of interaction that the modelling exercises tend to assume. Crowds are clusters of people. They're clusters of small groups. And if you stand on Bournemouth Beach on a bank holiday with a telephoto lens and you foreshorten the shot, everything looks completely jammed up. If you fly a drone overhead and take an overhead shot, what you see is that beach is full of small groups. Mm-hmm. People who have, by and large, people who've travelled there in the car together. They've maybe met another household. People who are maintaining a distance, as much distance between the groups as they can manage, as they can comfortably manage in that environment. They may walk down past other groups to the sea in one direction. They may walk past to the ice cream stands in another direction. But they're not. There is not this kind of pattern of random interaction and random mixing that is so often assumed. And the same applies, for example, to the Black Lives Matter demonstrations. People go to these events in small groups. They tend to stick with those small groups. It can become a problem if there's some kind of accident or other disruption to the event. That people are trying to move with the group or to rejoin their group. And often that's actually not helpful to their survival or to their prospects of avoiding injury. But this is something that is well understood within a certain part of the social sciences, but was not really picked up on elsewhere, and that applies quite generally to crowds. If you were looking at Glastonbury, or you were looking at, as I recall, Simon, your pleasure in going to the Chelsea football ground. You kind of go with your mates and you sit with your mates and
you do.
That's it. You're not randomly mixing with 50,000 other people.
No. And there's a science to this, as you said, and when we were chatting a little bit earlier, you were describing the origins of the science, which I found absolutely fascinating. This is proxemics.
Yes, there's a social science. Yeah, there's a social science of social distancing, which goes back to the 1950s, and an American anthropologist called Edward Hall, who was training diplomats, American diplomats. And Hall, one of the things that Hall noticed was that people in different cultures tended to stand a bit closer to Americans than Americans found comfortable. And one of the things that he was trying to train the diplomats to recognize was that if somebody was 20 centimeters closer to them than they liked, although of course it would have been in inches being American, but that this was not something that they should be spooked about. And they shouldn't kind of keep backing away until they hit a wall and couldn't back away any further. And that's been developed as a research field. We know pretty well that humans do not like to get much closer than a meter to people that they don't know particularly well. It's one of the markers of people you know well that you let them get closer to you. Your spouse, your partner, your children, your dog, whatever. The field's sort of developed and it's come and gone a bit. But the really exciting stuff now is in areas that the biomedical world just has no engagement with. So you have it in things like transport and architecture, where if you're designing a shopping mall or a transport hub, you need to know how much space to allocate for the people going through it so they don't feel overcrowded. Or if you're building a factory where humans and robots are going to collaborate, then you need to program the robots so they don't get uncomfortably close to the humans. And there's a body of knowledge there which should at least qualify some of the understanding of social distancing that has come from, for example, experiments in engineering laboratories, where the potential variables around airflow, virus transmission, the size of droplets, the size of particles, the size of aerosols, the distances that they can travel, needs to be calibrated against this sort of understanding of natural settings, and the sorts of interactions that humans have clearly been engaging in for as long as we've been on the planet.
So tell us then a little bit how this might apply. There's concerns about, for example, supermarkets, which obviously we'll have to use, and how people behave there. When we were chatting, you gave a very good example that had never occurred to me actually, but about how social distancing works in a supermarket.
Yeah, well, firstly, you need to understand that large modern supermarkets they have ventilation systems which in 2019 would have operated to take all the gunge that humans breathe out anyway up and away, because the supermarket chains don't want you breathing it on their produce. So you have these, that's one of the things that is a prime concern to the designers. When you get into a supermarket, again, it's a bit like other kinds of crowds. Typically you're either there on your own or you're there with one or two other family members. So you're going around as a group. You're trying to avoid intruding on other people's personal space. You may be standing next to somebody trying to get something off the same shelf. But if you video that, it's not face to face. You're trying to avoid engaging with them. There's a whole etiquette of doing that. Mm-hmm. You go around with your trolley. The trolley itself constitutes a barrier to getting too close to people. And then at the end of the process, you're standing in a line with the trolley, which is probably keeping you something like a meter apart from the person in front of you, face to back. So at no point going round are you spending very much time in the sort of close face-to-face interaction that is clearly high risk from the point of view of transmission. And that was as true in 2019 when we might have been concerned about influenza or any of the other 30 or so respiratory infections that humans suffer from. And that is the sort of thing which, if you need to talk to engineers who do supermarket ventilation, you need to talk to people who study behavior in retail environments. You need to bring in an array of expertise that is not normally encountered in the biomedical sciences or in the medical profession, in the professional work of medicine.
I think that's a very fair point. Just a couple of interjections from the audience. One, Osran Tosic is asking, again, words matter. Do you think we would have behaved differently if the word we were talking about was physical distancing as opposed to social distancing? Because obviously what we're talking about is actually physical distancing. Mm-hmm. Do you think do words matter? Would have that had an impact if we'd gone for physical distancing as the overall term?
Well, words certainly matter. I think it's the interaction between the social and the physical that is, and maybe the point is that what we have is physical distancing, which has been called social distancing, if I can put it that way. That we've had a model of distancing behavior that has come very much out of experimental work in engineering, translated into models, translated into into risk assessments, but which hasn't fully engaged with the study of things like airflow and ventilation in natural settings, and it has even, I mean, some of that has come in, but what has certainly not come in is the understanding of the social and the way in which physical and social distancing interact. I mean, if you're walking down the street and you see somebody coming towards you, I mean, from about 5 meters, you're starting to, to adjust your position on a pavement in order to avoid walking into somebody. And you've got that, that process of adjustment. Now, if you're walking down the street and the person who's coming towards you is your partner, maybe you don't start to take avoiding tactics because you're going to greet them and you're going to recognize them, and maybe you're going to embrace them if you haven't seen them for a few days, and you're actually going to get very close to them. And I think that what we've perhaps failed to do is to think about the messaging in terms of the social behavior and the social distancing, and put too much emphasis on the physical distancing.
So, and fair point. The second question, a perfectly reasonable question Jane Manfred is asking, it's all very well on the beach, but they've got to get to the beach somehow, and presumably via public transport. Those observations don't work so well on public transport.
Well, I think with public transport, one of the things that we might want to think through is, frankly, whether we should be improving ventilation standards on public transport.
Okay.
I mean, I early in the last 2010, 2015, I was doing a lot of work in transport studies, and with colleagues who were looking at the resilience of transport networks in the face of climate change, which was an interesting experience for many things, because the transport world, for example, is much more skeptical about modelling, and I learned some very interesting things about modelling from that community. But one of the things that we actually looked at was why aren't British transport systems, fully ventilated and air conditioned to the sorts of standards that you might expect ahead of much hotter summers. Mm-hmm. And I actually took it up with the local bus company, and they said, well, we've never thought it was cost effective. There's an energy demand on our buses from running air conditioning and providing the sort of ventilation that you provide in a supermarket. But that is something that would be taken as standard in Southern Europe or parts of the United States that I've been in, where the ventilation standards are just much higher in public transport. I mean, if you're sitting on if you're in an aircraft, I mean, airplanes are fundamentally very safe environments, because the quality of the ventilation, partly because a lot of passengers have sort of complained about things that they've picked up. You're in this sort of space that's compartmentalized by the seats and the seat backs. You are almost in a little bubble of your own, with a ventilation system that is changing almost to operating theatre standards. So we do, I mean, there are solutions to many of these issues, but you need to bring in people who understand about transport and transport ventilation, and to bring them into the conversation. Okay. I think the other problem with the beach is there was a lot of very unsavoury stuff about having to clear up the human waste that was left behind and so on, and it was really, councils got very upset about that. But then you were thinking, well, look, guys, you closed all the public toilets.
Yes.
Where do you expect people to to go?
Yes, I think that's a yes, or you only have one open. So there's, which I've seen, you close all the others, one open, so you have a massive queue in front of one. I've certainly seen that, and that seems to me extremely stupid. I have to say, and I've seen that quite a lot actually. Really bizarre pieces of kind of social engineering that completely backfire.
Yeah.
Now, in your different stages of the pandemic, I want to move on to the pandemic of action, which is basically the need to do something. Now, of course, no one advocates that you should do nothing, and you obviously don't do that either. But the desire to be seen to be doing something, whether it works or not, or indeed whether it's ineffective. So let's talk a little bit about that. And lots of people are asking about the topic of the day. I'm not going to name them because there's quite a few actually, in various ways. They're asking about, are vaccine passports an example of being just doing something because you can do it, or is it a solution, or indeed is it another way of an unintended, that might be unintended consequences? So basically, you've been talking about this. So talk a bit to us about vaccine passports, certificates, whatever we're going to call them.
Okay, we're fairly short of time because I've been rambling on in answer to your questions. But, let me make confine this to 2 points. Firstly, I think vaccine passports are a good example of something which is intended to reassure, but actually potentially perpetuates fear and anxiety, that you cannot venture out into the world without risk and without proving that you do not represent a risk to anyone, or that other people do not represent a risk to you. It's a bit like some of the things being said about face masks. There may or may not be evidence that they work, but maybe we should make everybody wear them just to remind them that there's a pandemic on, and that they.
Gabriel Scally, I think, yes.
The Gabriel Scally line,
yes.
The second thing, though, which is, I think,
is that wrong? What's wrong with that?
Well, again, you have this issue about to what extent is it appropriate to go on perpetuating fear when that fear may be quite disproportionate to the risk. And isn't it potentially the role of government, the role of experts, to be adjusting public perceptions to the level of risk, rather than continuing to amplify it or to try to sustain it at a high level? The other point I wanted to say about vaccine passports is that I'm just not sure what the point is in a vaccinated population. I think I was explaining to you, Simon, the only working model is the Californian porn industry, where it's really important for you to know somebody else's immune status before you start engaging in a performance with them, because we don't have a vaccine for HIV. Now, we do have a vaccine for COVID. We have very effective vaccines for COVID. They effectively reduce the risk of serious injury, of serious infection or death, to that of the pack of other respiratory viruses. I mean, I'm not going to say where in that pack of 30 odd viruses COVID lands.
No, don't worry. Yeah.
But somewhere around that. So if you're protected by your vaccine status, knowing the vaccine status of the person sitting next to you in the pub doesn't matter, because the only risk to you is of that mild respiratory illness with a comparable risk of needing hospitalization or mortality. And that risk is very heavily age loaded, very heavily loaded towards, it's very much loaded towards specific groups, where one can think about specific advice on protection.
I guess, and obviously people will be saying, well, first of all, the protection is not absolute, which is absolutely true. But the other thing they're going to say, yes, but a lot of people are not having vaccines. And I want to put to you the question Martin Bellman has put, and which is actually germane to this. Maybe what you say is true, but there is the carrot of a vaccine passport. If that's the only way that's going to allow me to go to Chelsea to watch football, then I'm more likely to be vaccinated. And his question, it's the last question, is are carrots or sticks the best way to persuade people to comply with the rules? I would say, are carrots or sticks the best way to persuade people to get vaccinated? And if a vaccine passport is a carrot, which I think it is, what is wrong with that?
Well, in general, I think carrots are better than sticks.
Mhm.
But I think that we also have to take account of the unintended consequences. What I would also say is that I think we're trying to cross a bridge before we come to it. You know, all the evidence that we have so far is of enthusiastic uptake of the vaccination in the groups to whom it's been offered. Now, that may or may not be the case as we move down the age cohorts. But I don't think we should be working ourselves into a state now about, will the 18 to 29-year-olds be less enthusiastic than the over 80s about getting vaccinated? We haven't actually put that invitation in front of them. And the evidence that's emerged so far seems to be that when you actually invite people, they come with much more enthusiasm than you would think from the survey data on intentions.
Okay, fair point. And then my last question, Joseph McMahon has said, slightly with tongue in cheek, that sociologists are very good at explaining what has happened, not so good at explaining what might happen or what we might do. So I put that question to you now to say, you've been around in pandemic planning for a long time. Given that, and given what you've talked to us now, in terms of the early stages of the next one, what would you do differently when the next sick pangolin comes too close to the shopper in the next wet market and we hear about it? Given your expertise, what is the one thing you think we should do that we didn't do for the next time?
Well, I think the crucial mistake this time was overlooking the societal challenge and the societal nature of pandemics. And I think one of the big issues for the inquiry that's coming, that will inevitably come, as I think Gus O'Donnell said to you, is have we got the right kind of structure for dealing with this sort of challenge? And that structure is going to have a much wider range of scientists involved, draw on a much wider range of expertise, because it needs to recognize that it is not dealing with something that is just a biomedical problem, just a public health problem, just a problem for the Department of Health. It's dealing with a challenge to the whole society. And it needs to bring expertise into the fold that is capable of dealing with that.
I think that point is extremely well made. Trish Greenhall, who we love and has been a great supporter of this series, and we love having her around. She did say, I think possibly with tongue in cheek, she talked about academic sparring can keep a few sociologists amused during lockdown. You've done much more than amuse us. I think you've made a very clear case for why academic sociology in general, should be much more at the center of this. Now, don't go. I just need to do a couple of announcements. So this time next week, we are getting back Sharon Peacock, the head of the COVID Genomics UK Consortium. This is her second visit in a few weeks. I would like to say she's welcome. Welcome isn't quite the word, because her subject is, of course, new variants of the virus, and I would be delighted when we never have to call on her again. However, she was an absolutely brilliant speaker, as you will all remember, and sadly, her knowledge is more in demand than ever. So come back next week and listen to Sharon. She may not cheer us up, but nevertheless, she will certainly inform us. And in this chair will be Andrew Jack again. This time on Wednesday evening, change of pace in our Slow in Conversation series to David Clementi, another of the good and the great of this country, and the last chairman of the BBC will be our guest with Roger Kirby. Now, as I said, Sharon is a very compelling speaker and very well informed, but she's not the only compelling speaker in command of her game. You've also heard one today. Thank you so much, Robert. And I just want to quote what Shabir Haroon has said. He said, "My God, you should have had Professor Dingwall on episode 12, not episode 62. So that's the other change we will make. When the next epidemic comes around, we're going to get you on sooner, much rather than later, Robert. And I think you did. You set out to show why the social sciences and sociology is just as vital as the other disciplines. And I think you have proved your point and also kept us all really interested as well as charmed. So thank you so much. Thank you for taking the time for this. And we will undoubtedly see you again, Robert.
Thank you very much for asking me.
It's a pleasure. So good afternoon, everybody. And don't forget, this time next week. Okay. Oh, and I should also say, don't forget that otherwise my president will be on to me. Don't forget the Royal Society of Medicine. We still need your support. Life is not back to normal. We're still struggling. So if you're feeling in a generous mood, please give generously. We certainly need it. Okay. Take care.